أعزائي طلاب المرحلة الرابعة، السلام عليكم ورحمة الله وبركاته. Today we will talk about drugs that are affecting bone metabolism. And mainly we have three major disorders in the bone that we are interested. These disorders are osteoporosis, Paget disease, and osteomalacia. But what are the differences among all these disorders? Osteoporosis is characterized by a loss of bone mass and decrease in the bone mass. And also there is an increase in the skeletal fragility. Patient with osteoporosis always suffering from the increased risk of fractures, and there is significant increase in the morbidity. Osteoporosis occurs mostly in postmenopausal women and older adults of both sexes. While Paget disease is the disorder of bone remodeling that results in disorganized bone formation, malformation of the bone, and also there is an increase or enlarging in the bones or misshapen bones, which means that these bones are either big or these bones are present with misshape. Paget disease is different from osteoporosis because it is affecting mostly one or few bones, unlike osteoporosis, which affects maybe all the bones in the body. Patients with Paget disease also experience bone pain and bone deformities, and also there is an increase in the fracture and the morbidity. While the last one, osteomalacia, it can be defined as just a softening of the bones, and it is mostly related to the decrease in the vitamin D concentrations or levels in the body. And here we have the drugs that are now used to treat these disorders, but mainly we will talk about the osteoporosis and sometimes about the Paget disease, because with osteomalacia, I think it is easily managed just by vitamin D replacement. Let's start first with the bone remodeling. What is the meaning of this process? Bone remodeling serves to remove and replace damaged bone and maintain calcium homeostasis. I think it is not like increase the level of the calcium in the bone, increase the bone strength, and decrease the bone softening. Here we have mainly two major players, osteoclasts and osteoblasts. Firstly, with osteoclasts, these cells are known as the breakdown cells or destructive cells that are breaking down bones and decrease the bone strength and the mass. And the process that is led by these cells, it is known as bone resorption, decrease the density of the bones. After the bone resorption, there is an activation in the osteoblasts cells, or it is not, these cells are known as the bone building cells, which are synthesizing a new bone and increase the bone mass and density. Also, we have in the bones, there are crystals which are known as the hydroxyapatite crystals. These crystals are deposited in the bones and increase the bone mineralization and bone density. So at the end, there is increase in the bone strength. After these two, let's say, phases, the phase one is led by the osteoclast, the phase one is led by the osteoblast. There is what it is called the resting phase, when there is, like after the bone remodeling, there is like a resting phase for a while until the remodeling phase happens or starts again. Then what is going on with the osteoporosis mainly is there is imbalance between the bone resorption and bone building processes. So there is increase in the bone resorption, and at the end there is decrease in the bone density. And these are just pictures for real bones shows the differences in the bone density and the osteoporotic bone in the comparison with the normal bone. But how can we prevent osteoporosis? There are many steps in these strategies, and these steps are including like adequate intake of the calcium and vitamin D, and there are certain kinds of the exercises. If the patients are not able to take enough quantities of calcium and vitamin D, so there is a need here for the calcium and vitamin D supplementation. Mainly the calcium, the form of calcium that are now used to increase the level of the calcium in the body, we have calcium carbonate and calcium citrate. Calcium carbonate, it is like easy and commonly prescribed as a calcium source, and it contains like around 40% of these of calcium carbonate is calcium, so it is a rich source of calcium. And but this one should be taken with meals for best absorption. On the other hand, we have calcium citrate, and this one provides around 21% of calcium, so it is a less rich source of calcium in comparison with the calcium carbonate. However, it can be better in toleration, so it is better for patients, and also there is no need to be taken with or without food, because food does not affect in the absorption of calcium citrate. Mainly we have major adverse effects with these two supplementation, like gas and bloating, and calcium may interfere with the absorption of many drugs and preparations such as iron, thyroid replacement, fluoroquinolone, and tetracyclines, etc. On the other hand, we have vitamin D, and vitamin D, it is very helpful not only for osteoporosis, but as we mentioned previously, also for osteomalacia and Becher disease. And mainly it is it presents in two forms, either D2 ergocolcalciferol or vitamin D3 colcalciferol. Both of them are good sources as for vitamin D. Also, on the other hand, these are the major supplementations, calcium and vitamin D. Also, it is important for the patient to avoid the drugs or the preparation that are increasing the risk of bone fracture or bone loss, such as corticosteroids. So now let's talk about the treatment of osteoporosis. Mainly the treatment for osteoporosis is warranted or is required for postmenopausal women, patient over 50 years of old, or there is mineral density, it is much below the healthy young density, or there is a low bone mass, osteopenia, decrease the bone mass. So all these are the major indications for patients to use the osteoporosis treatments. Let's start first with biphosphonates, and here we have multiple drugs such as alendronate, risedronate, zoledronic acid, and these are the preferred ones in the treatment of osteoporosis. And also we have others such as itidronate, ibandronate, and bamidronate. Also, the last one, tylodronates. These are very important drugs to treat both osteoporosis and Becher diseases. And also they are now prescribed for a patient with malignancies if there is a metastasis for the cancer to the bones and decrease the bone density. Their mechanism of action, it is so easy. These drugs just bind to the hydroxyapatite crystals. These are the calcium crystals in the bone, and inhibit the osteoclastic bone resorption. So they are decreasing the bone resorption through decreasing the osteoclast activities, resulting in a small increase in the bone mass and decrease the risk of the fractures. The beneficial effects of alendronates could persist for years after discontinuation of the treatments. But at the same time, it's not gonna be on the same level. There is a decrease or there is a gradual decrease in the bone mass. Here, just to show there is an increase, how the bone density increased with the biphosphonate. So with the years, like up to 3 years, how much the bone increase, there is significant increase in the bone density. So these are very beneficial drugs. With the pharmacokinetics, these are very poorly absorbed drugs from the gastrointestinal tract. So it is like around less than 1% of these drugs is absorbed. Also, these drugs are hugely affected by food and other medications. So it is better to like put a time window or separate these drugs from administration of other drugs that could affect on their absorption. The other features in the pharmacokinetic of these drugs are not staying in the plasma for a long time. They are immediately cleared, but they stay in the bones for years. So their biological half-life, it is much longer than the plasma half-life. Elimination mainly through kidneys. Patients who are not able to tolerate oral biphosphonates, it is recommended to use intravenous administrations of biphosphonates, such as zoledronic acids or ibandrolone. This table just shows differences between these drugs and how much like frequencies or the time to administer of these drugs. These drugs are different. So we can see here, like with the all of them can be, let's say, administered orally, except zoledronic acid only intravenous. Also, ibandronate can be administered by both routes of administrations. And also they are different in the like daily, weekly, or monthly, maybe yearly with the zoledronic acids. So the time window or the frequency of the dose, it is hugely different from one drug to the another. But here we have very important notices about how to take these drugs if they are taken by oral administration. It is important to take like plenty of water with them, like during taking these drugs. Also, it is important to like put like around 30 minutes as a time between the administration of these drugs and the food, drink, medications in order to prevent the effect on the absorption of these drugs. And also, it is important to tell patients to stay on the upright position, not on the lie down, because these drugs could affect on the esophageal, as we will see in the adverse effects. So these 3 points are important, like plenty of water, put a time window between these drugs and administration of other medications, and also the upright position of the patients. Adverse effect, we have gastrointestinal adverse effects such as diarrhea, abdominal pain, and also in addition to the musculoskeletal pain. These drugs, alendronate, risedronate, and ibandronate, these drugs are associated, like it is very common with them. There's an increase in the incidence of esophagitis, esophageal and esophageal ulcer. So the first 3 steps that we are, or points that we are talking here, it is important to prevent these adverse effects. So a patient should be told to stay on the upright position, plenty of water, and spread them with the time. The risk of also we have that the risk of atypical fractures seems to increase with the time. I mean, with the time of using these drugs, biphosphonates. So it is recommended, like there is what it is called a drug holiday, like stop using these drugs after, let's say, 5 years with the biphosphonates. I mean, the oral ones, and 3 years with the zoledronic acid, which is parenterally administered drug. Here, this table shows the anti-resorptive activity, which means the bond building capacity of these drugs, and we can compare between the efficacy and potency of these drugs and how much they are affecting on the resorption process of the bond. Then we have denosumab, and denosumab is a monoclonal antibody. This drug is affecting or targeting what it is called kappa B, or a nuclear factor kappa B ligand. This is a master transcription factor affecting in the DNA transcription of proteins that are involving in the cells activation, function, and proliferation. And it seems that denosumab is affecting this transcription factor and decreasing the osteoclast formation and function. It is approved as a first-line treatment for postmenopausal osteoporosis in women at high risk of fracture. Also, there is another advantage that this drug can be administered like subcutaneously every 6 months. So it is a very long time to administer the next dose. Also, denosumab is very beneficial, as we said previously, for postmenopausal women, and also for patients who are elderly or at high risk of fractures. The adverse effects are associated with these drugs. It is common with the all monoclonal antibodies, like there is a disturbance in the immunity and the inflammatory response. So there is an increase in the infection, dermatological reaction, and also maybe there is an increase in, there is hypocalcemia and osteonecrosis. Then we have parathyroid agents, and here we have mainly two drugs, teriparatide and abaloparatide. This one is a recombinant form of the human parathyroid hormone, while the other one, it is an analog of parathyroid hormone. This is agonist. It is a direct agonist, while this is resembling the parathyroid hormone, the endogenous one. These drugs are agonists at the parathyroid hormone receptors and can be administered like once daily by subcutaneous administration. And this is an important difference from all the other drugs that are used for osteoporosis. These ones, the only ones that are increasing or enhancing the osteoblastic activity and increase the bone formation and bone strength, unlike all the other agents are we said. Of course, these drugs are, could be also causing some side effects such as hypercalcemia, orthostatic hypotension, and maybe there is an increase in the risk of osteosarcoma, but these are in the animal studies. Also, there is, let's say, a drug holiday. Like these drugs are not recommended to be used for more than 2 years. Then we have calcitonin. Calcitonin, it is indicated to treat osteoporosis in women like with a history of more than 5 years of postmenopausal symptoms. And the drug, this drug reduces bone resorption similar to all other agents, unlike parathyroid agents, but it is less effective than, let's say, biphosphonates or denosumab. So they are now not, calcitonin is not used now for treatment of osteoporosis. But there is an advantage, very important advantage, like there is a characteristic with this drug. It causes a relief of pain, and it is very beneficial for some patients, especially patients like after, let's say, fracture or an accident. So sometimes it is prescribed for treatment for painful vertebral fracture. Now, this drug is used by intranasal formulation, so sometimes could cause rhinitis and nasal symptoms as adverse effects. Then finally, we have selective estrogen receptor modulators. With the low estrogen levels, we talked a lot about postmenopausal women and postmenopausal symptoms, and it is none like the estrogen levels or concentrations inside the body. it decreases significantly in the postmenopausal time. And this decrease in the estrogen level seems increase the activation of osteoclasts and more losing for the bone mass and bone density. So, according to this theory, it is easy just to prescribe estrogen for those patients in order to decrease the activation of osteoclasts. But due to the adverse effects that are associated with the estrogen, like such as endometrial cancer, breast cancer, stroke, venous thromboembolism, coronary events or accidents, these are hugely affecting on prescribing of estrogen as a replacement therapy. Now there is a new concept about using estrogen or the theory of estrogen for osteoporosis is by using raloxifene. And raloxifene, it is called like selective modulator. Selective modulators means that this drug sometimes is agonist in certain tissues and the other times it is an antagonist in other tissues. In this case, in our case right now, raloxifene is a estrogen receptor modulator. Of course, it is approved now for treatment and prevention of osteoporosis, but this drug has estrogen-like effects on bone, and what it is recommended in our case, this is estrogen effect or agonist effect. While it has antagonist effects on other tissues such as breast and endometrial tissues, so this causes like decrease the side effects or the incidence of side effects that could happen with estrogen replacement therapy. Therefore, raloxifene increases bone density without increasing the risk of other side effects. Because it has not been it has not been shown that this drug could reduce the non-vertebral or hip fracture, raloxifene should be used like as an alternative therapy. Still, we have the first-line treatments for osteoporosis, bisphosphonates, and monoclonal antibody. Adverse effects similar to the other estrogen. Side effects such as hot flashes, leg cramps, and increase the risk of venous thromboembolism. To here, I thank you for the listening for this lecture. Of course, if you have any questions or comments, just let me know in comments. Thank you very much.